First of all, we'll talk a little bit about some definitions of random sampling and random allocation. We'll talk about the common allocation strategies, and then I'll tease you a little bit with some new approaches that have been used in some other areas, not so much in orthopedics, but I think we might be ripe for some of these techniques to be used. And then spend a little bit of time on the mechanics of randomization and how to do it manually and how to think about doing it electronically. So a random sample, if this is the entire population, you want to do something with your sample that reflects so that you can summarize, you know, what's the average height, the average weight, the average whatever of the population. So you take a random sample of the population. There are techniques to do that so that you can then extrapolate your findings in the sample and describe the entire population. But random allocation is a little bit different. You've already got a sample, and this is where, you know, sometimes you do a fancy randomized study and it may or may not get published, and somebody says, well, that's not applicable because your sample isn't representative of the population that I'm interested in. So my population looks different than your sample, or you're at a specialized teaching center where your sample of open fractures is very different than the population, so your randomized trial is not relevant. So you have to make sure that whatever sample you start with, it's representative of whatever population you want to generalize the findings to. Then, of course, you do some random allocation and you get treatment A and treatment B. Now, it's important to recognize, and I know you've already gone over this, that randomization of this sample into group A and B only controls this type of bias, the selection bias, that group A and B are relatively similar at the beginning of the trial, and therefore, when you get a difference in outcome, you can say that's due to the intervention, the treatment. But there are all sorts of other biases that can still occur in a randomized trial. So the point being, if you do a randomized trial and do it badly, and have differential follow-up, or you do your measurement differently, or there are co-interventions besides your primary treatment, that can be a dangerous thing, because in fact what you're doing is you're doing a randomized trial, so people say, oh, it's a good study design, but if it's not done well, you can have an erroneous result that people might believe and that might mislead people. So again, you've already talked about this. The randomized trial is the best way to compare treatments and to really establish a causal link between the exposure of the treatment and the outcome. And, for example, the smoking lobby argued for many, many years that nobody had really proven that smoking causes lung cancer or causes coronary disease. Nobody's ever done a randomized trial of smoking versus non-smoking. So, to establish a causal link between exposure, treatment, and outcome is very, very difficult in the absence of a randomized trial and requires a lot of other work. And, of course, randomization is the essence of what we do in a randomized trial. So let's talk about the easiest form of randomization. That's simple randomization. So in other words, every person has an equal chance of being in treatment group A or treatment group B, and it's as though, you've got a fair coin. If there's two treatment groups, you flip this fair coin, and they either go to group A or group B. So that sounds like a very nice sort of thing. One mechanical way of doing this is a random number table. So you've got this random number table, and you can decide how to read the numbers mechanically. But here it doesn't show up that well, but this is, ones are treatment group A and zeros are treatment group B, let's say. And, if you get an odd number, you go into group 1. If you get an even number, you go into group 0. And this is an actual random number table, and this is an actual section down here where you can see 1, 2, 3, 4. They've got 12 ones and 2 zeros in this particular section of the table. So just by chance, random chance, you've got in this group of 14 patients, you would have 12 of them assigned to group A and 2 of them assigned to group B. Now that's fine if you're doing a randomized trial of 1,000, because eventually it'll equal out, and there'll come a time later on in the trial where you've got 14 group Bs and 3 group As in a row maybe. But if you're doing a trial of 20 or 30 patients and your accrual is slow over time and you're getting these patients in, there might be a significant bias if you're entering 12 of them into one treatment group and only 2 into the other. So that's a problem with simple randomization. The groups might not be exactly equal. And not only is it a problem in terms of the unequal size and temporal problems and so on, but statistically it's much neater if you've got equal groups in allocation. So when might it be a problem, simple randomization? If you've got a small randomized trial. A small randomized trial is something less than 200. 200, 100, that's considered a larger randomized trial. Think about it, when does that occur? Well, if you're randomizing clusters, what is a cluster? So if you're randomizing families or hospitals. Let's say hospital A gets, some sort of treatment or some sort of protocol. Hospital B, gets something else. So, you're gonna have hundreds and maybe thousands of patients, but maybe only 4 or 5 hospitals. The same if you're randomizing a whole family to a treatment, let's say of some sort of prophylactic intervention or whatever. In a multi-center trial, if you've got 10 centers, those centers might be accruing fairly slowly, but at least you want to have some sort of treatment A and B in each center. You don't want to have one center with all treatment A and the other center with all treatment B. So if you're randomizing the patients as they come into all the study centers, you might have a situation where one study center doesn't have an equal allotment of treatment A and B, and that might be a problem because, at Mo, being an expert surgeon, he might do all of treatment A and get really good results, and me, being an inferior surgeon, I might get all of treatment B and get really bad results, when in fact treatment B is the better treatment. It's just because they happen to be randomized to me. So you can see that that's a problem. So the other thing is, all of you are familiar with randomized trials or have seen randomized trials that have gone on for years. So there was a large Canadian study of calcaneus fractures, non-operative versus operative treatment. Went on for over 7 years. So, the recruitment is fairly slow over time. Over 7 years of a randomized trials, things might change a little bit. It might not just be the treatment. There might be better rehab, better anesthesia, different types of injuries or whatever. So you want to keep a balance of treatment A or experimental versus control over time so that you don't have all of treatment A at the beginning of the trial, all of treatment B at the end, and one might look better than the other because of other things that have changed that affect the outcome. So all of these things make a simple randomized trial potentially problematic. So block randomization is a way of overcoming that. And very simply, you develop blocks. In this case, we've done blocks of 4. So if you have blocks of 4 and you keep the numbers of treatment A and B equal in those blocks, so these are the different ways you can keep those numbers equal. You can have ABAB, AABB, BABA, and so on. So there's 6 different ways when you've got blocks of 4 of keeping the number of A's and B's equal in the block. So if you consider now that when a patient comes along, and here's a group of 4 patients, they get randomized to a block. So instead of this one being randomized to A or B, this one being randomized to A or B, this group of 4 gets randomized to one of these 6 blocks. And then, the first one, if they're randomized to this block, gets treatment A, this one gets treatment B, and so on. So that you can never be unequal as you're recruiting by more than half the block. All right? And we can go through that. You can sort of prove that fairly easily later if you need to. So block randomization is good because it keeps the treatment groups equal and keeps them equal over time. But, if you're smart and you've had, a patient come in and he gets assigned to treatment A, and you know that the block size is 4, the next one gets assigned to treatment B, you say, the next one could be A or B. Well, if the next one's B, the last one has to be A because, it's A, B, B, A. So you can guess the allocation if you know the block size, and if it's a small block size. You might say, well, let's have a block of 50. Well, that's great, but again, if it's a very large block size, you can, again, get unequal groups as you're going through. You won't be able to guess it. So one of the things that's done is variable size blocks. So a block of 4, a block of 5, block of 6, and people aren't supposed to know what the block size is, and then it becomes very hard to guess. Consider, though, that the whole idea of blocking is to keep the treatment groups equal. So we're in a randomized trial right now, and it's extramedullary versus intramedullary fixation for proximal femur fractures. We've had 3 intramedullary fixations. So, just by chance, you've got 3 of one treatment group, but you know darn well that, the blocks are there to equalize treatment groups. So I will bet that probably the next one we get will be extramedullary, right? Chance is that we're not going to get 4 of one treatment group. It could happen, but, so even with larger block sizes, if you're starting to get unequal, you can sort of guess what the next treatment group is going to be, and that could be a potential problem, right? So just be aware of that.